for the memory of rainy afternoons, swingy Harlem tunes, motor trips and burning lips and burning toast and prunes. How lovely it was. Thanks for the memory of candlelight and wine, castles on the Rhine, the Parthenon, and moments on the river line.
Just the last name of the day.
Hey, ladies and gentlemen, welcome back. Take your seats. Our next speaker is Dr. Lady Martinez. She is a geriatric psychiatry fellow from the University of Texas Health Science Center in San Antonio. And today she's going to be giving a talk on barriers to diagnosing dementia in the Hispanic population. So please give her your full undivided attention, and thank you very much. Please give her a warm introduction. Thank you.
Can you hear me okay? Yes. Okay, great. Well, so today I'm going to be talking about a very important topic, and the reason why I chose this is because I think awareness is what's going to save us from the dementia epidemic that is coming up by 2030 actually. I know Dr. Salazar spoke a little bit about the projections, but I'm going to just give you more details into what's really going to look like for our elderly population and what can we do with this mixed population that we have here in Texas and in other parts of the United States. So I'm going to start with saying why this topic is important. And as you might see in future slides, the Hispanic group constitutes the fastest growing subpopulation among the aged in the United States. The number of Hispanic elders suffering from Alzheimer's and related dementias could increase more than sixfold, from fewer than 200,000 today, or when they did the study in 2009, up to 1.3 million in 2050. So the strong cultural value of family responsibility is a strength of the Hispanic communities, and studies have demonstrated the high sense of filial responsibility for elders, particularly among Hispanic daughters. As a result, these families, particularly daughters and other female relatives, provide a disproportionate share of the Alzheimer's care. And they do so for longer periods of time and also at higher levels of impairment than the non-Hispanic groups. This also means that Hispanics are less likely to be living in long-term care facilities and are more likely to be living with relatives than any other minority group. And this other slide just illustrates what I just said about the Hispanics as a minority group having the fastest growing segment in the aged population in the United States. And you see the projection right there. And then how the prevalence of dementia for Hispanics, it's going to increase by sixfold to from 200,000 right now to up to 1.3 million by 2010, 2050. There is evidence that Hispanics are at greater risk than the population as a whole, given the prevalence of known or suspected risk factors for dementia, and these are the vascular disease, diabetes, and lower education levels. Consideration of dementia is confounded by the heterogeneity of the Hispanic population in the United States, with widely differing origins, levels of acculturation, generational experience, language proficiency, educational level, psychosocial and economic status, cultural traditions and beliefs. So you can see how heterogeneous is this population that we're trying to take care for. And these variables must be taken into account in designing research, services, and policies to address the issue of dementia in Hispanics and the needs of those individuals and families affected by this disease. continue here. So, as I just said, Latinos face high risk of Alzheimer's disease and others dementias. And why is that? Well, age is the single greatest risk factor for Alzheimer's disease. The prevalence doubles after age 65 and every 5 years and reaches about 50% by age of 85. Education is another risk factor and appears to have, like the higher education level you get, it appears to have some protective effect against Alzheimer's, but unfortunately, Hispanics have the lowest education levels of any group in the United States. 1 in 10 Hispanic elders have not had formal education, and over half have had 8 years of schooling or less. There is also the cardiovascular risk factor, and growing evidence indicates that vascular risk factors, again, like diabetes and vascular disease, are risk factors for both Alzheimer's disease and vascular dementia, which often come together. So this other slide here just shows the percentage of cases with a specific type of dementia by ethnicity. And if I might point here, you can see that the Hispanics right here are the second group after Caucasians presenting with Alzheimer's disease, and the third group here with vascular dementia. So as the population continues to increase, we're going to be more at risk, and we're going to surpass any other group by 2010. As alarming as that sounds, we have to also say that Latinos are not receiving the health care needed to reduce their risk or manage their dementia. And why is that? Well, the evidence suggests, and this is reinforced by our clinical experience, that Hispanics with dementia are low users of formal services. They are less likely than non-Hispanics to see a physician, and much less likely to use services provided by other health professionals. Among adults with diabetes, high blood pressure, or heart disease, all potential risk factors for dementia, they are less likely to receive services to help monitor and control those conditions. So as you can see, that they are not only at risk, but prevention is not really taking an effect on them. This apparent is only apparent because services are there, and we're going to talk about those services later on. But this apparent failure of the healthcare system may increase the risk of dementia for Hispanics because it delays the identification of the disease and the diagnosis of the dementia. It also leads to high levels of impairment and heavy and prolonged caregiver burden. And what does exactly mean, well, there's a delay in the diagnosis of dementia? Well, as Dr. Salazar explained to us, unfortunately, we don't have any cure for dementias, and the medications that we can use to slow the progression only by 6 months, the better one, appears to have a better effect at the beginning of the symptoms. So these families may come to us too late when the medication is less likely to exert any good effect. So the earlier that we diagnose somebody with dementia, the most likely that he will benefit from the treatments we have available right now. Research is only beginning to sort out the complicated picture of dementia among Hispanics. And there is the shortage of well-trained bilingual and bicultural clinical researchers, as well as of normed and standardized language proficient assessment instruments. And these have negatively influenced diagnosis, management, and service utilization patterns of this population. An example of this, and I was just reviewing the literature to see what has been done if we know that this is a problem. And there was a study by an author in 1998, Stripes, and he found that Spanish-speaking patients have been excluded from many treatment trials because of the lack of Spanish language assessment tools. So what that means is like if they cannot objectively measure response to treatment, it's better not to include these patients in the study because it will decrease the scientific evidence for the study. So they have been included because we don't have validated assessment tools, or we didn't have by this time. And another author, McCracken, in 1997, studied prevalence rates of dementia and depression among different ethnic minority groups and found higher levels of dementia among non-English speaking groups. However, the sensitivity and accuracy of the diagnosed dementias were shown misleadingly high for those who did not speak English. And the comment that the author made is like, could you imagine how easy it would be for you to look demented if you were not understanding the instructions that you were given or did not really know what they were asking from you. So it would be pretty easy to say, well, this patient may have a cognitive disorder or some retardation, something. So also, they also found that these results were not normed by age or education level. So we can also assure you that many patients that might be in the borderline zone, not really diagnosed with dementia yet, but you have some suspicion, you also have to take into consideration their age, because for their age, they might be performing at what is expected, but also for their education levels. And now we have normed some of the cognitive tests we're using for education and age. So now we're going to be talking a little bit about what are those obstacles in the diagnosis of dementia, what is making really difficult, and excuse me for 1 second. So let's see here. This slide shows many factors that do not necessarily represent a problem for Hispanics, but for access to healthcare as a whole, in the whole population. Some of these are accessibility, getting or having a professional to do a dementia assessment, language and communication, mistrust, acculturation, knowledge, discrimination, finances. So you can see how one or all these factors can interfere with access to healthcare. And for the Hispanic population in particular, which is our topic today, personal and family values, beliefs, and attitudes are really important. And what studies have suggested is that initial symptoms in this population are not thought to be the beginning of something potentially more serious. Moreover, they are considered normal aspects of aging. And also, there is a lack of knowledge in the population about Alzheimer's disease and other dementias. There is also fear of identifying the disease in a family member, given the association with stigma, discrimination, and disadvantages. There is also distrust of outsiders and resistance to sharing familial problems with them or admitting that the care is too demanding, that there is caregiver burden. There is also some acceptance and stress as a normal and expected part of the familial role. And in this slide, I just wanted to illustrate with a little humor where we're coming from in terms of, even though we are trying to raise awareness as professional, the Alzheimer's Association and other organizations, even when we see this campaign in television, we might not really pay attention to it because the information may not resonate with the population's belief and attitudes toward illness. Like I said, the most rationalized explanation is this is just related to age. And even though they're seeing, well, these are alarming signs, then the information is just disregarded in most cases, unfortunately. Then, in the other side over there, you can see how patients have expressed, their fear of recognizing that they're having some cognitive problems because they feel that what they have to say is going to be disregarded or that they are going to be treated less positively because they're impaired. So there is fear. Another Another important aspect for this population is the English proficiency. And a large number of Hispanic elders are first-generation immigrants who are not necessarily comfortable in English or trusting the healthcare system. There's also, again, the shortage of bilingual and bicultural staff in many healthcare systems, and these have negatively influenced the diagnosis and the management of these patients. Another important thing is the cultural biases in cognitive testing and inadequate translation of diagnostic tools that may skew diagnosis of dementia in Hispanics. And even though significant progress has been made in developing culturally sensitive tools, they have not been standardized or normed across subgroups of Hispanics, nor are they widely used outside of academic and specialized research settings. So these cognitive assessments, even though we have developed more culturally sensitive instruments, they are not being used in the community, only in academic centers and specialized research units. There is also, older Hispanics have far less health insurance than their non-Hispanic contemporaries. And it's that more than 1/4 of Hispanics aged 50 to 64 who have a chronic condition are uninsured. Less than 1/3 are covered for the prescription drugs that they need to take to manage those conditions. And Hispanics aged 65 and over rely solely on public insurance, so the Medicare or Medicaid, in higher proportions than the non-Hispanic groups. And even though I have said all these factors that may play a role making it difficult for the Hispanic elders to access healthcare, it is not totally clear how these diverse factors interact with each other to influence the Hispanic elders in their efforts to gain access to the complex healthcare system in the United States. But my hope is that by creating awareness, we should be better able to facilitate their access, and our patient is not in that position that old lady, not really knowing what to do, and with obvious physical and potentially cognitive disabilities. And I just wanted now to tell you a little bit about 2 studies that I found, because even though we realized that this is a problem, I said, well, have this population been studied? Have people really investigated what is really causing the problem? Because the services are there. We know that dementia is a growing problem, and it's a chronic condition like diabetes and high blood pressure. So I only found 2 studies, and they're not too new. One of them is these barriers to healthcare access for cognitive impaired older Hispanics, and this is from 2000. It was published in the Alzheimer's Disease and Associated Disorders journal. And what I found that this study was interesting is because they wanted to really take a look at what I think they took 67 patients with their caregivers. But to meet the definition of caregiver, this person needed to have daily contact with the patient for at least 6 months. So they were interviewed, they were evaluated for dementia. Once they met the diagnosis or the criteria for dementia, they were given this questionnaire that they call the VAS. And it's a 7-minute questionnaire which touched in 7 categories of questions asking of some potential barriers to care. And they asked the patient and the caregiver to rate, what was more difficult, what elements, and I'm going to show you how it looks like, and I'm sorry that I'm going to have to read to you because I know I couldn't make it more clear, the slide, but this is the questionnaire they used, and they divided the barriers in 7 categories. And let's see here, yeah. So we had first economic barriers, and these are letter B. Here you have whether the patient and the caregiver felt that they could afford the evaluation process. That was one of the questions for economic barriers. Then we had the the family support barriers. Then we have the language barriers, the English proficiency barriers, the transportation barriers, among others. And what I'm going to show you now is from this small group sample from Los Angeles, California, was for this population, what were the most significant barriers in accessing the healthcare system? And I have to say that the biggest percentage was given to personal beliefs. And their findings suggest that perceptions regarding illness, life attitudes, values, and beliefs about health and the utility of medicine influenced healthcare use, even when a physical or financial barrier did not impede healthcare access. So now you can see how education is a big portion of what we have to do to create awareness, because it's the personal belief of this population that is really getting in the way, for the most part, as explained by them. There was also the, and I'm sorry, I was coming in Spanish. I gave this talk in Spanish too. But language proficiency, 33% was the second most common barrier. And in this example, the language proficiency is strongly correlated with low acculturation and education levels, regardless of the number of years living in the United States. So the mean number of years that these patients had living in the United States was 26.6 years, but that didn't mean that they felt comfortable in English or that language proficiency was not a barrier. The third and most common barrier was economic status, and only by 13%. But you can see in that illustration that others, like lack of transportation and time, immigration issues, like fear of being deported or reported to the immigration services, poor family support, and distance from the clinic did not surpass the personal beliefs and not having bilingual, bicultural providers available. Another study, the second study that I found, learning from recruitment challenges. This was a slightly different study, because what they wanted to do in this case, they wanted to help diminish the caregiver burden. So this study was designed for caregivers, and even though that they offered to the participants to go to the home, it was going to be a home-based intervention, because they acknowledged that caregivers are very busy taking care of these patients. Transportation can be an issue, finances can be an issue. They offered to bring the problem to their home settings. And even though that was the case, at the end of the study, the major problem was that more than half of the patients recruited, and there were only 29 patients recruited, failed to meet the criteria for Alzheimer's disease, but not because they didn't have it. It's because that the symptoms that were reporting to them were part of normal aging. So one of the criteria to be admissible to the study was to meet the criteria for Alzheimer's disease, but if they said, no, I don't have Alzheimer's, then it was going to be kind of hard to sell. The second thing, again, was that the caregivers, even though that they were told, well, this is going to help reduce the burden, you want to have more free time, we're going to take the services to your home, they said that it was one more thing to do in 24 hours, and that they just couldn't bear with that. It was just one more thing to do. And at the end, they declined to join the study. So at the end, what we can say about this is that the Alzheimer's Association has already been sounding the alarm in terms of the epidemic that is coming up on us, and the campaign has already started. They have divided this in 3 strategies that are interrelated, and like I said before, so research is going to be numbered. Research and education is going to be first, with a focus on minority groups. The second is going to be education and outreach aimed at risk reduction, early diagnosis, and treatment of these communities. And I have to say here that remember that the Alzheimer's Association contact number, 24 hours, 7 days a week, and they do have bilingual available professional personnel that can assist you regardless of where your location is. and also community health and social support services for patients and families. I think we have started to move in the right direction, and my hope is as we raise awareness of this problem, we will be in a better position to offer evaluation and treatments to our aging population. These are the references of the studies that I showed you and some of the literature review that I did, and thank you very much.
There's plenty of time for questions if anybody has.
Swingy hollow tune, motor trips, burning lips, burning toast and food.
All right, well, thank you very much.
For the memory
Okay.
of candlelight and wine, castles on the Rhine, the Parthenon.
And moments on the Hudson River line.
How lovely it was.